So we're going to get started here. Hello, friends, and welcome to the 5th episode of Think Free, a screencast that we've created to dive deep into some of the most pressing health issues today, and also to have some fun during this coronavirus lockdown, which seems to be ending any minute now or any day. And we are joined tonight by our Chief Science Officer, Avisha Nesaiver, as well as our newest team member, Jordan Crofton, currently serving as medical administrator of the Well in New York City. My name is David Choi, and I want to thank you so much for tuning in and helping to make our brand of edutainment a staple in your daily diet of useful information. And thank you to our donors for helping to make our work and wellness a reality. If you know anyone who could benefit from the wealth of knowledge contained herein, please do take a moment to share this with your friends and family on social media. And if you haven't already, please like us on Facebook, follow us on Instagram, and subscribe to our most amazing, awesome weekly newsletter. And tonight, we are going to dive into chronic pain, which is something that many of us experience on a daily basis, including you, Avisha. Is that right? Do you, what's your experience with?
True, unfortunately.
Unfortunately. And on a scale of 1 to 10, how bad is your chronic pain?
Thankfully, these days, it's probably a 2 or 3. There are occasional times when it flares up to the 5 or 6 level, but that's when I'm doing everything that I know is wrong, and it just continues to get worse. Just the background, I've got some chronic back pain that is actually upper back rather than lower back. It started when I was hanging upside down and something slipped. I'm pretty sure that's what most people spend their afternoons doing, but I had to actually—
You were doing your acro yoga?
Bar. Yeah, you know, the preparation for it.
Oh, the preparation for your acro yoga.
I like to spend 5 to 10 minutes just like inverted every day anyway. It helps to get that lymphatic fluid flowing. But
nice.
It was quite entertaining for my roommate when I suddenly had to be like, excuse me, can I get some help here? I'm stuck.
Oh, gosh. All right. How about you, Jordan? Are you familiar with chronic pain? What's your experience?
You know, I am. I've been lucky personally not to really deal with it on a large scale at all. I think, you know, it's also hard not to have the conversation of chronic pain and not bring up the opioid crisis, which
I know.
I've really seen a lot doing clinical hours in the hospital and during my time at Emory. And I think that it's such an important conversation to be having because the opioid crisis in a lot of ways has brought to light just how prevalent of a problem this is and how many people are living in chronic pain, but furthermore, just how inadequate a lot of our more conventional treatments are for dealing with it. And, you know, I think it's easy to see how, you know, doctors and practitioners, they don't want their patients to be in pain. They want to make things better. And, you know, sometimes they feel like they have limited tools in their toolkit. So, you know, in the hospital, especially, you can really see how acute management can turn into chronic dependence. And, you know, there's kind of a cycle of it. But I think that there's some exciting new research. There's new treatments being developed. You know, it's an area that still needs more research, but I think it's a great conversation to be having and an important one. There was just a pretty recent article in the New England Journal of Medicine that came out, and it's showing that at least 30% of Americans are dealing with chronic pain, if not more. You know, that number is way higher in older adults. So this is incredibly prevalent, something that, you know, most people will experience at some point in their lives. And I think the more smart brain power we can get on this, the better.
Absolutely. And that's why we brought in the big guns tonight, Dr. Tanuj. But before we get into that, before we bring him up to help us understand chronic pain a bit better, we have a little bit of trivia for you all. Compliments of Physiologic, one of New York City's premier functional medicine clinics. And the winner of tonight's trivia is going to take home a digital copy of Ben Greenfield's Boundless book, as well as an initial consultation with our esteemed expert pain doctor, Dr. Tanuj Palvia, valued at $350. Total winnings tonight will be well over $400 worth of biohacking goodness. All right, so here some ground rules here. If you once you have the answer, you're going to message it directly to all panelists and not to the entire chat group, but you will be submitting your answer through the chat to only the panelists. All right, when you're ready, Here it is. So in the past week, we've been taking an introspective look into our antiquated and broken systems. And one aspect of governance that we're particularly keen on as a major public health threat is the mass incarceration of Americans, which, like many of our social ills, disproportionately affects African Americans. In September 2013, the incarceration rate here in the United States was the highest in the world at 716 per 100,000 of the national population. And while the United States represents only 4.4% of the world's population, it houses 22% of the world's prisoners. And so here's the question. What percentage of released prisoners in the United States returns to prison after committing another crime? This is also known as the recidivism rate. Is it A, 40%, B, 26%, C, 60%, or D, 76.6%? And we are going to paste this into the chat unless, well, it looks like people already heard that. Okay, so I'm going to repeat it one more time. A, 40%, B, 26%, C, 60%, or D, 76.6%. And we will announce the answer and the winner at the end of the show. And so now, Avisha, can you please introduce our featured speaker?
Thank you, David. And what an interesting trivia question. Definitely a shift from the typical random biohacky type questions. So today I am very happy to introduce Dr. Tanuj Palvia. Dr. Palvia is a recognized leader and specialist in regenerative medicine and non-surgical orthopedics. And pain medicine through the American Board of Anesthesiology. He received his medical degree from the University of North Carolina and completed his anesthesiology residency at NYU Langone Medical Center. Dr. Palvia then completed his interventional pain management fellowship at the Center for the Study and Treatment of Pain at NYU, and there he developed his expertise in diagnostics and minimally invasive advanced thoracoscopy, not to be confused with the really invasive stuff, and ultrasound-guided procedures for the treatment of tendons, ligaments, nerves, joints, and muscles. Dr. Palvia is one of the few physicians in the world with extensive experience in the clinical application of adult stem cells for the treatment of musculoskeletal injuries. I could really use some of that. He believes in an evidence-based multidisciplinary approach, and with his 4 phases of care strategy, is able to tailor treatment plans to patients' specific needs. Those phases are relief, strengthening, wellness, and regenerative care. He is dedicated to holistically alleviating patients' pain and suffering while improving their functionality and quality of life. Dr. Palvia grew up in Memphis, Tennessee, with roots in India. He is fluent in Hindi, and his free time, he enjoys spending his time with friends and family. When possible, he loves to explore everything New York City has to offer, which these days is, you know, a lot of good park time. So, Dr. Palvia, thank you so much for joining us, and could you just say hi to everyone?
All right.
There he is.
Hey, everyone.
There we
Can you hear
go.
me?
We could hear you loud and clear.
Hi, everyone. Thanks for having me. Thank you, Avisha, for that introduction.
So glad to have you.
All right, thank you so much. And let me just say, I've had the opportunity to speak to Dr. Palvia a little bit, and I'm already very impressed with his breadth of knowledge and look forward to diving into that a little bit. But before we really dive into your experience on a clinical setting, could you tell us a little bit about, you're an expert in pain management. So how did you go from your experience through medical school or even earlier in life to really end up in the position you're in with the very particular niche focus that you've chosen?
It's a great question. Thanks again for having me. I'm so excited to be here. And yeah, that the road to get where I am today, there was a lot of trial and error, and just trying to figure out what I like. Avisha, your and my background are similar. My first love was mathematics in elementary school, and then I was interested in gadgets and whatever, and I decided to apply to engineering. My dad's an engineer, had a lot of influence on me, and so I studied engineering. I studied electrical engineering, like you, Avisha. And that, that was great in principle, but, when I got out, I wasn't really sure what I wanted to do for the next 50 years. So after some soul searching, I got interested in medicine. My mom is actually a physician, and she had athlete. I'm your science guy, okay? And I slowly became interested in medicine. Between college and med school, I did some anesthesia research. I was involved in that, and that sort of steered me towards that path through medical school and then through training. But, you know, the engineering roots really spoke to me, and I think problem solving and analysis of a situation is what really brought me to pain medicine, which is obvious. You know, it can be very puzzling and it can be very challenging. And oftentimes, if you can solve someone's chronic pain issues, it's very, very rewarding. So it's a little cliche, but that's sort of what took me there. Of course, I still do some anesthesia because, you know, I think it's really cool. So half my patients are asleep and half my patients I put to sleep just by talking, but hopefully that won't happen tonight.
Hey, you save a lot of money on anesthetics that way.
The other thing that you have in common is that both of you are accomplished rap artists, right? So I hear. No, I'm just kidding. But both of you have, didn't mean to put you on the spot. But Dr. Palvia, come on.
Speak to whoever is submitting my bio there. Got to have a little chat with them tomorrow.
I'm going to say nobody wants to hear me rap.
But Tanuj, Dr. Palvia, you did have a little history in freestyle rap. Is that not true?
I can't argue with that. That is
okay.
I mean, that is true, yes.
We're not going to ask you to rap on the spot, but I really just wanted to throw that fun fact in there.
That, David.
All right, cool. So thank you for giving us that initial, like that road to becoming a chronic pain doctor. But so tell us a little bit about chronic pain. I know you wanted to take us through a little bit of information there.
All right, very good. So chronic pain. So before I even jump into this part, I want to really just talk about what is pain. Pain, you know, if you study in a medical textbook, it says pain is basically a person's response to a noxious stimuli, which if you really think about it, how that is a completely subjective phenomenon. Everything in medicine can be measured. David, I'm a big fan of your But point is that pain is one of those things that how can you quantify other than saying on a scale of 1 to 10, what is your pain score? And that's very subjective. So the biggest challenge in treating chronic pain is really trying to identify what is that pain and where is that coming from? And so that's how I really approach all my patients. I want to tell you a little bit of just about where I am and what I do. I'm based out of New York City. Specifically, I'm in downtown Brooklyn, right across the bridge, Brooklyn Bridge, rather. And I work at a great place called Physiologic in downtown Brooklyn, which is basically an integrated medical center, medical and wellness center, really just right in the heart of downtown Brooklyn. We service the entire New York community, but even outside that, especially in these times where teleconferencing has become a mainstay, we're really reaching a wider population. But we have 10 different disciplines and we have over 35 practitioners, and we all work together to really focus on a patient's presentation. What is causing the pain? What is that pain producing tissue? We explore that, we identify that, and then we really work from all angles to try to address that. If we can't solve it, at least try to maintain and minimize it. And so what I've written there is every person who comes in here really gets a personalized treatment plan. And that's what that kind of speaks to our times today. You know, 30 years ago, tell someone that you have a knee problem, and they do an X-ray, and then they'll say, all right, well, here, take some Advil, and if that doesn't work, then maybe you should go get surgery or something like that. But nowadays, that's really evolved a lot, and that's what I'm going to talk about going forward. Of course, the last point here, it's about maintaining a healthy and a pain-free lifestyle, and pain-free, if not pain-free, at least pain minimized, pain optimized. That's our goal. Specifically, what do I do? This is sort of my model. This is my model my general recipe that I'm always thinking about every single day with respect to all my patients. Again, pain is very subjective, but there are objective reasons for pain. And those are the things that we really want to try to figure out. So whether that person is my athlete who comes in, who's trying to get back in the game, maybe they were sidelined, they went too hard one weekend on their run, and now their knee's killing them. or if it's the person who just kind of worn things out, maybe a little bit not in the greatest health, or even your elderly person who's dealing with a chronic condition, we really want to identify what caused that. And so if that's a degenerative influence, such as poor posture, Avisha, I'm looking at you, okay? I'll get to that in a second. And if it's an injury or if it's just technique in the sports that you're doing, these kinds of things are very important to identify, because you could be caught in circles trying to chase that pain generator if you don't correct what's causing it. And also on a cellular level, it's very important to optimize what our body's health level is. You're not going to repair an injured tissue if those cells at a microscopic level are not functioning correctly. And that's what I refer to as a healing environment. That's that functional medicine component, really making sure that you've optimized that environment where all of your cells are, that they can continue to thrive as long as possible. So that's a big part of what we do here. And then of course, once you're at that level where you're ready for treatment, regenerative medicine is really transformed my practice in terms of really trying to get patients that second chance at performing at that high level that they were before they sort of fell into this chronic pain cycle. And then of course, when we reach those goals, we have to maintain them, because as I tell all my patients, we're all degenerating. We've all started degenerating from the moment we've exited the uterus. And so really the process is to really decelerate that process, or even halt that process if we can, at least for some period of time. And that's done through maintenance and promoting a state of wellness, and with the hopes of actually reversing the process that got that person there in the first place. A lot of my patients have seen this simple diagram right here. Objective markers of pain, again, very important. So, you could say my knee hurts, or my back hurts. Someone comes and says my back hurts, but why is that? Why are you feeling that way? Is it your posture? Is it your technique? Is it your lifestyle? Is it the stress in your body that's causing your muscles to tense up, that's causing you to move the wrong way, which is then promoting a vulnerable state, which would lead to injury. And then how you're coping with that. And I know we'll probably touch on this a little bit later, but the biopsychosocial model of pain presentation and treating that pain is very important to address with all patients. If you have a patient who has a depletion of serotonin, if they're depressed state, or if they're fatigued, they're not literally going to be they're not going to necessarily be in that optimized state of health to promote that healing that they need, so that they can stay maintained and achieve that level of wellness that we want. That's one of our endpoints for our patients. One thing, a lot of you may have seen this diagram before. Usually you see it with arrows, but it's important to point out that this goes both ways. Pain will cause fatigue, fatigue will cause pain. Mental anguish will cause pain, pain will cause mental anguish. So, this is all a singular presentation, and all of these things need to be evaluated when patients are seeking relief from chronic pain issues. This slide is very busy. Just to touch on this, what I mean by whole body optimization. I'm a product of the modern medical system. The modern medical system is highly specialized, but our focus here at Physiologic is more of an integrative model and a functional model. A lot of times if you say, I have, let's say, a heart condition, you'll go see the cardiologist and he'll give you a blood pressure pill. I know that's a very simple example, but just trying to illustrate that the problem started at the root. And so down here, I don't know if y'all can see my pointer, but basically what caused that person to have elevated blood pressure that led to a heart problem? Is it poor nutritional intake? Is it their energy levels? Is it how they're coping with their stressors? All these things can cause a systemic problem that then gives rise to organ system problems. And so while it's important to treat the symptoms, which is up here in sort of the flower of this model, the only way we're really going to reverse that disease process is focus on some of these roots. And so an evaluation for chronic pain definitely entails these components as well. And then once we're really trying to go for that extra level of performance, again, my athlete who wants to become a super athlete, or even my person who's dealing with chronic pain, who's like, hey doc, I want to get it back into biking, or I want to get back into racing. That's where we start talking about regeneration. And this is a big focus of my practice. And this is where the future of really treating chronic pain is going. Just in brief, what is a stem cell? A stem cell is one of your main tools of regenerative medicine and being able to revitalize, re-strengthen, and regrow damaged tissue. And I don't want to get bogged down in the slides here, but basically a mesenchymal stem cell is the type of cell that can differentiate into different orthopedic tissues. So if you're having a regenerative medicine evaluation, we really want to try to assess how this tool can repair that site of injury. And how do you actually deliver those cells to a stem cell to a damaged tissue? That's done through the discipline of interventional pain management. So chronic pain over the last 50 years was basically just kind of throwing a pill at the situation. But over the last 20 years, and really in the last 5 to 10 years, as technology has caught up in medicine with the principles of medicine, now we can use imaging guidance as a way to deliver regenerative therapies right to the very millimeter where it needs to belong. So for example, using some of my tools here, you're seeing a fluoroscopy machine. Off to the side is my ultrasound machine. Sorry, it's not in this picture. The point is we can, with high resolution, deliver modalities to these injured tissues with the hopes that that accurate level of treatment will promote regeneration and recovery. And these are just some slides of some of the applications of what I do. This person right here is getting a stem cell treatment into the discs. So some folks who have herniated discs, who deal with sciatic type symptoms, that is a very difficult chronic pain situation. A lot of times if we can revitalize and re-strengthen these discs, we can get a resolution of symptoms. And the same thing goes for some of these other parts right here. This is a person with hip OA, osteoarthritis, a very painful chronic disease. Here's a rotator cuff injury. This person had a supraspinatus tendon tear, which is one of the muscles employed by the rotator cuff. And then just a couple of pieces of literature here. The goal, in orthopedics, my field, or interventional pain management, or now what's being called interventional orthopedics, is to try to avoid the operating room if we can. Now, I'm not against surgery. There's a role for surgery, definitely. If someone breaks a bone or if someone snaps a ligament in half and it's displaced, you're gonna have to get someone to go in there and fix that. But the thinking of the 1980s and 1990s, where everyone gets a knee replacement or everyone gets an ACL reconstruction, that's starting to fall out of favor as data emerges. And this particular study I've quoted here comes from Regenex, which is a national organization of doctors that have really kind of banded their knowledge, their data, their experiences and their results with their patients to come up with the best regenerative therapies that they can deliver to patients. We are the first Regenex location, or rather practice, in New York City. And so, this is sort of the data that you can expect to see coming from our clinic as well. In this particular study, folks with type 1, 2, or 3 ACL tears, about 77% showed 72% reduction of pain up to 23 months out on average. And that's very, I'd be happy to discuss this in detail later on, but in the interest of time, I just kind of want to move on to my last point, which is also, I'm a big believer in medical marijuana. It's transformed my practice in the last 5 years. As Jordan, or Joe, I think you go by, expressed the concerns with the opioid epidemic. It's really sort of turned our country upside down, and actually the world upside down, in terms of how patients are able to get by in their life. And unfortunately, sadly, a lot of times this dependence becomes a fatal issue. And so therefore, I've really embraced medical marijuana in the past. As a pain physician, we're sort of stigmatized into pill pushers, but marijuana is great as an anti-inflammatory. It's great for nerve pain. It's great for muscle spasms. It's great for joint-related pain and arthritis. And it really has all those effects, and it has barely any dependence potential, certainly leagues above chronic opioid use. And so I'm a big believer in this. And like I said, it's really transformed my patients, my practice, as well as my patients' ability to deal with chronic pain. And that's pretty much it. I hope I didn't ramble too much, but there's my contact info. And I'd love to hear your thoughts about what we're discussing today.
All right, thank you. That was quite a in-depth discussion there. And I just hope that none of these patients you spoke about on the last stage have a lot of cookies lying around, because, that's the difference between opiates and some of the other potential prescriptions. Not that I'm a fan of opiates. So just to
glad.
what was that?
I said I'm glad.
Good. So just to dive in a little bit more, throughout your practice, when you're looking at all these chronic pain patients, there are some of the obvious causes for pain, like not to name any names, but some people who might not always have perfect posture while working from home for all their lives. And that could be a cause for varying types of back pain. So that's something that those people might understand could easily be a cause for such pain. But throughout your practice, have you seen any particularly weird causes that you were able to identify? Like, oh, that backpack was just way too heavy, or just anything that comes to mind as something a little off the beaten path as a cause for pain that people might not really think about?
Definitely. Let's talk about the current times. Well, I don't know where everyone is, but I'm in New York, and I know David is. Avisha, actually, I don't know where you are.
I am in New York as well, Upper West Side.
Okay. And Joe, you're in New York too?
I'm actually in North Carolina right now.
Oh, I'm from North Carolina. Where are you?
I'm in Figure 8 at the moment.
Where?
Figure 8.
Great. Okay. My family's from Greensboro. I think
fabulous. Okay.
I think some of them are listening, so shout out to Greensboro. But anyways, so to answer your question, before we even get into off the beaten path, I think all of us, every week on my iPhone, I get a reminder that my screen time has gone up by 8,000%, as well as Zoom calls. Actually, I'm not very good at Zoom considering how much I've been using it. Apparently, David, thanks for pointing out that I'm not that great at Zoom.
There's a bit of a learning curve.
Yeah.
So
Okay. But the point is that all of us increasingly, and I would say even more so in the last 3 months, have been doing a lot of this and a lot of this and a lot of that and a lot of this, right? And so posturally speaking, I think it's worse than ever. And that's the presentation I've been seeing in my clinic. We open back up on a limited basis. And I think in these current times, that's the biggest one, is postural related. We're all sort of deconditioned to a certain degree. We've all fallen out of our routines, our exercise routines, even just like stretches. We're working more from home. For me, I got 3 little kids. I don't know when it's morning, when it's night. I'm on my phone all the time trying to get work done. And so I find that a lot of these things that we would ordinarily see have become amplified. And so a lot of presentations, even younger folks, I'll see arthritic type presentations that you wouldn't expect, until maybe later in life. Sometimes I'll tell a patient, hey, I think the pain is coming from your joints. I think you have arthritis. And they say, what do you mean? Having arthritis doesn't mean you're 90 years old. Arth literally means joint. Itis means inflammation. Itis of anything is inflammation. Inflammation of joints can occur from anything. And so a lot of people positionally experience spine joints, which are called facets, facet-related pain in their necks. That's a big one I'm seeing nowadays. And even in general, just, overall inflammation from deconditioning, I think is one of the biggest things we need to be cognizant of these days. We've all fallen out of our routines, myself included.
Same here. I've definitely fallen out of my routine, but I feel like I've actually recovered from my routines, because I was just going way too hard, and I was having all kinds of like shoulder issue. I still have this recurring knee thing going on. But it's feeling a lot better now that I'm not like throwing so much weight around, I feel like. But so I had a quick question while you were saying all that. Do you ever get this, well, we're talking about the biopsychosocial approach, and you have people, is it ever like in their head, like the pain? Yeah, it's all in your head, buddy. Like it's, I know it's very like, it's all self-reported, right? You ask like, what's your pain level? What if some people just have so much more grit, so to speak, right? And what's your take on that? Like, just kind of man up.
That's such a great question, and I may start rambling a little bit, so feel free to interject. Okay. So somatoform pain, that's what you're referring to. Somatization of pain basically is almost a psychiatric diagnosis, which is saying that, exactly is what you said. It's all in your head. Through my training, I would a lot of times, you're getting some behind the scenes here, but a lot of times when doctors come and see you and then they step out the door, they'll talk to their nurse and say, yeah, I think it's all in this person's head or something like that. As a med student, that really left a really poor taste in my mouth.
Mm.
I have certain family members who've dealt with chronic pain for a long time. I do think that it can be coupled with mental disorders. I think there's a very strong correlation. Things like anxiety, chronic depression, these things are definitely correlated with your ability to deal with pain. Pain pathways in your system, in the spinal cord, they become upregulated because they're sort of in this fight or flight state all the time, trying to fight this whatever anxiety, whatever it is, right? And so what happens is that these pain pathways become amplified. So yeah, when something is, again, a noxious stimuli, it may cause more pain to that person where ordinarily it wouldn't cause pain for your average person. So those psychiatric conditions do exist, but to me, they're really a diagnosis of exclusion. And who are we to say that it's in someone's head? We don't know what's in that person's head. Why? Because I have a degree, or or let's say someone is really in touch with their health. Who are we to say that it's in someone's head? Who the heck knows what's in anyone's head? So I don't think that's really fair. And even if it is something like that, I think addressing those mental components, as I showed in that diagram before, is very, very important. And I think it's as an MD, it's my responsibility to guide those patients in that direction. To really understand. And if there is some kind of generator of pain, it's our job to find that generator of pain.
For the record, I do not want to discount anyone's pain or chronic pain and say it's all in your head. You just need to man up or get stronger. But we do say, or we have done a talk on chronic pain, and we have the topic of there being a community. Like, as long as they have, when you have friends to talk to about your pain, it becomes a lot less painful. I don't know. That's kind of what people say, that there is this social approach, this community approach to dealing with chronic pain.
Absolutely. I mean, that goes for anything, any kind of, anything that, even physical or psychological or anything, if you have someone who's next to you, who's kind of going through the same thing or similar kind of thing, then the doc who 2 days ago told you it's all in your head is probably wrong. So I think focus groups and even things like group therapy, for example, fibromyalgia is a very, that's a whole nother discussion, but there's a lot of fibromyalgia focus groups that sort of help coach each other into how to get through those things. And, most of us know a friend or family member who kind of deals with that sort of diagnosis. I find that focus groups are very, very effective for dealing with that.
There's someone very close to me with fibromyalgia that I've been helping for quite a while now. And towards the beginning of that path, I read a study that was looking at 50 different fibromyalgia patients and testing them for gut issues. And they ended up finding that I think it was 45 out of 50 fibromyalgia patients tested positive for SIBO. And we tested her, and sure enough, she did have SIBO. And over the course of like a year-long journey of doing things to try and combat that, it did actually have a marked difference on her overall pain levels. So is that something you see a lot in terms of the gut pain connection that's being expressed in totally different ways?
Absolutely. And there's a scientific explanation for that. The enteric nervous system is the most aside from the brain, is the most complicated nerve organ. I'm not saying that eloquently, but I think you understand what I'm saying. Neurological organ besides the brain. So any kind of disturbance in the gut is going to be perceived with pain input, and it's going to amplify what the rest of the system is seeing. So that makes a lot of sense. And we do SIBO testing in our clinic as well. And that's one of the first things I discuss with patients is, what are you putting into your body? Because if you do have a sensitive gut, that could be amplifying some of the things that you're dealing with. Fibromyalgia is a constellation of symptoms. It's chronic pain. It's sleep disturbance. There's usually a mood disorder, a lot of musculoskeletal pain, joint pain. We actually, latest research actually was published last month that a lot of our joints also have a flora in them, like a microbiome in those joints. And so if your enteric system, meaning the gut, is agitated, you're going to trigger a systemic response in your body, an inflammatory response that's going to cause those aches and pains as well. So there's a definite connection, I'm glad you found someone who can address that. It's very important.
So we were talking before about the psychosomatic connection, and I know there's been all sorts of interesting research on this. One thing I used to do back probably in college was when certain people would complain about these various issues, I would often go to them, they'd like, oh, I have a really bad headache. I would give them a massive, massive bright red pill and say, I don't tell anyone I gave you this, but it is an insanely potent painkiller. Now, what I didn't tell them was that it was omega-3s, which come in these massive pills. And they would take it and come to me a couple hours later, be like, yeah, you know, I don't know what you gave me, man, but I want some more of it. So do you ever find yourself, I know that ethically speaking as a doctor, you would never be allowed to do something like that. But do you ever adjust your overall presentation or the way you're dealing with patients in such a way as to try and build up a treatment or cure or intervention in their minds so that they really get on board with it as a way of enhancing recovery?
Meaning faking pills and giving them fake pills and
I'm not going to say actually faking pills, though I'd love to hear if you have given that. But just in terms of the way you approach their treatment from the way they're viewing it, like how do you approach that side of things, even when you're talking about actually concrete interventions?
Yeah, so that's a bit complicated. Definitely, I think coaching a patient into having good insight as to how their pain is presenting, not even where their pain is coming from. For example, if you've ever hurt a body part, let's say knee. Okay, I'm going to pick on David for a second. Let's say you've hurt your knee, and you're like, "Oh, that really hurts. What am I going to do?" And you go to the doctor, and usually within the first 3 sentences, I'll hear, "Well, I think I need an MRI." Okay. All right. So yeah, you need an MRI. All right. So let's say you, I don't know, tore a ligament. Well, how did that happen? How did you tear that ligament? That's what we really want to get to, because let's say we get that ligament to correct somehow. It's what you've been doing throughout your life, and really, let's say in the last year, what kind of stress. Now, I'm not picking on you, David, by the way, because you're obviously in greater shape than me. But point is that what are you doing to that knee that got you there in the first place? Is it the junk that you're putting in your body? Is it the modality of exercise that you're doing? Is it that you're overdoing it? You know, so I think the perspective that needs to be gained is very important. And that's a big part of treating chronic pain. Chronic pain is that, right? You can have an injured tissue, and it's the corrective process over time. That's how you're going to deal with it. I'm not sure if that answers your question, but long story short, there's a lot of coaching that goes into patients gaining insight into what they've done or what they can modify in order to deal with their current pain presentation.
Oh, that makes a lot of sense. So I know you talked about all these amazing therapies and treatments you guys have access to. You've got your PRP, your stem cell injections, your prolotherapy, your ultrasound guided stuff. And while I, as a hardcore biohacker, would love all of this, for those people who either don't have the time, the money, the drive to go and try and get these sort of advanced therapies, on sort of an 80-20 approach, how would you go about, like, for our audience right now, are there any particular tips, tricks that you have for dealing with, say, chronic back pain that are good ways that anyone could implement right now for dealing with it?
Well, again, you know, I don't find a lot of every case is unique. For example, chronic pain can be categorized into something that flared up in the last week that, you know, bothered them, you know, maybe a couple times a year, something flares up. For example, oh, doc, my neck's been bothering me for the last week. But, you know, I rest and usually goes away, but this time it's not going away. So there's that chronic presentation, which is called acute on chronic, right? And then you have someone who just has chronic pain all the time. And that could be due to some kind of injury or maybe, I don't know, a surgery that didn't go so well or some kind of trauma. That person's dealing with chronic pain in a very different way. So, you know, I would have to try to compartmentalize, you know, those categories before I could really address that. But generally speaking, again, if you're having that pain, you want to ask yourself, why are you having that pain? So let's say you have someone who is dealing with back pain once in a while. What has caused that back pain? That's what you know, first question that comes out of my mouth when a patient comes in and says, doc, my back hurts. I ask them why. If they can't tell me why, we got a lot more work to do. Most patients will say, well, yeah, I've been spending a lot of time at my desk, or I went ham on some deadlifts, or, whatever it is, right? So I think really identifying that triggering factor is important. So in someone who comes in with an acute on chronic, one thing you want to ask them is, for things you want to focus on is, are you, let's say, I don't know, most of us are, well, I don't know about COVID, but a lot of people are sitting at a desk all day. So is it that your back is hurting at the end of the day? Are you taking breaks? Because your back will lock up, your muscles get stiff, the joints get stiff, even if you're young and healthy. So are you taking breaks? What's your posture? Is your monitor up here or is it down here? Are you hunched over like that? Are you sitting in a crappy chair? So a lot of things are just environmental, the kinds of things you're doing on a day-to-day basis. What are you doing in your routine potentially that is aggravating your pain? Are you eating junk? You have a crappy bed? Are you exercising wrong? What's going on there? So that I think is something that, that exercise I have with each patient. What kind of factors can we find in your lifestyle that we can modify to help mitigate the problem? So that's I think for that area. And then of course, if there's a more complicated case, like someone who's had a trauma or something like that, sometimes we have to sort of address what's going on in that area. So perhaps a model I explain to all my patients, your body has a certain equilibrium where it can handle a certain amount of pain or injury, deal with inflammation, and you can be pretty much fine. That's why if you ever ask yourself, well, why does my back hurt today, but last week it didn't hurt? It's because sometimes you're here, but sometimes you're out here. And usually that's because the injury side is aggravated. And what I mean by that is those tissues have actually become very inflamed. So sometimes I tell patients, if you start feeling it, you really want to get in the mindset where you can knock that inflammation out before it gets out of hand. It's easier to stay in front of pain than chase it after it gets out of control. So I'll tell patients that, a short course of medication might be your trick. We want to get you back over here, okay? Once you're out here, that's where you deal with chronic symptoms. We just want to bring you here. We might not bring you dead set, but if we can bring you here, then we can sort of redirect you down the right course. So that could be taking Advil for 3 days, knock out that inflammation. If you're tweaked your knee, you should be icing the hell out of that knee every single day. Ice is actually a very underrated anti-inflammatory. Sometimes we'll do an injection. Sometimes we'll do a cortisone. And, a lot of people gasp at cortisone, but there's a role for cortisone, for microdosing cortisone. Microdosing is kind of a fun term that people use these days, but it also applies to standard medications as well. If you're microdosing cortisone, you're basically putting that fire out so that you can then sort of get back to your equilibrium and head down that road of rehabilitation. So, I hope that answered your question. It's kind of complex, but these scenarios we work through with our patients so that they can really understand how to manage their chronic symptoms.
Thank you, Dr. Palvia. That was a great explanation. I would love to pivot for a minute and spend a minute or two talking about stem cell therapy, because I know you're such an expert in this area. And I'm curious if you could tell us a little bit more about what types of injuries or chronic conditions you're seeing it have the most compelling results. Is this more wear and tear, acute injuries, soft tissue, just kind of where you're seeing the best results on that? And then a piggyback question on it, is there any other research or developing treatments that you're really excited about that you see coming out in the near future? Or what are you looking at right now that has you fired up?
That's a great question. Now we get to talk about the fun stuff. First and foremost, kind of to segue from what I was talking about earlier, it's really important to understand the role of things like stem cells. Stem cells is a buzzword, but regenerative medicine is basically a way to rebuild tissue, okay? To my patients, I always give the example, suppose a building's on fire, okay? You're not gonna start rebuilding that structure until you've put out the fire. So if a patient comes in, let's say they were running and they felt a snap in their knee and now it's all blown up, okay? That's an athlete's injury. They may have tore their ACL, they may have chipped their meniscus, they may have just sprained another ligament or something like that. But that's not the point where you're gonna go in and start rebuilding that area. So first, again, we wanna bring them back over here. Once we have them here, now we wanna go down the road of rehabilitation and performance. So to answer your question, I find stem cells, we do stem cells over the last 5 years. I've been doing this. My applications have sort of evolved to anywhere from your run-of-the-mill tennis elbow that just won't go away, all the way to someone who's dealing with, I'm blanking on the word, osteonecrosis of the hip joint. So someone who has a really bad hip over the years, now we're actually going into the bone and putting those regenerative therapies in there to try to regrow that. If you remember that diagram that I showed, those mesenchymal stem cells are great for orthopedic applications. And so they work great in all these areas, but basically these are building blocks to sort of revitalize, rejuvenate those areas so that they become stronger and they can be rehabilitated. So again, all the way from tennis elbow to hip arthritis, ACL injuries, meniscal tears respond really well. So a lot of these like runner type injuries, patellofemoral syndrome, just losing cartilage. I'm in the last year of my 30s, so my knee cartilage is starting to go. That area, it's very, very important and beneficial, and I've seen amazing results with that. But even in chronic shoulders, rotator cuffs is a big one. The great thing about shoulders is they're not load-bearing joints. So rotator cuffs do really well because they can rehabilitate pretty easily. You know, if you're getting a knee treatment, you're still going to use your knee. You can't lay in bed for 6 months, right? And so it's a little bit, even though it's a little bit more difficult, knees, shoulders do really well. But you know, most sports injuries these days, acute damage of tissues, respond very well to stem cell therapy. And then your second question, what is upcoming? Well, stem cells are at the forefront. There's some other things out there, some buzzwords, which might be a little bit beyond the scope of this, but things like exosomes and peptides and things like that. I don't really, I'm not using those yet because I'm not super confident about the data. So everything we do is data driven. And the data on stem cells, particularly knee injuries and shoulder injuries, is very impressive. I tell patients, you know, this is especially the younger patients, but even the elderly, I mean, if you can avoid doing surgery, I think stem cells are the best thing that you can do. But some of the other therapies that I've employed also, PRP is great for strengthening tissues. So if you think of stem cells as sort of a seed to regrow tissues, the PRP, which is platelet-rich plasma, these cells will allow that area to sort of grow and become fertilized. Platelets are, of course, the cells in your body that permit healing. For example, in your skin, when you get a cut, it heals really well in a couple of days because there's good vascularity. And so those cells will migrate to that site and promote healing. But that doesn't happen in tendons where there's poor blood flow. That's why these procedures are done the way they are. Other things like ozone treatment, that's a big one that's coming back. It was actually very popular in the 70s and 80s, sort of fell out of favor. What's ozone? Ozone treatment is basically a hypersaturated oxygen molecule. So it's an O3 rather than O2. And oxygen, which is aerobic versus anaerobic. The philosophy is, as I told you, a lot of these joints where there's chronic injury and inflammation, there's sort of a imbalance of the flora in those joints, which kind of promotes that inflammation and sustains that injury. So if you can introduce a hyper-saturated oxygen treatment into that area, similar to like hyperbaric oxygen therapy, those kinds of things, then you can really decrease that inflammation and cause healing in that area. So ozone has probably been the biggest thing in combination with stem cells that I've used to sort of transition a patient from an acute injury into sort of a chronic state of healing and wellness.
Excellent. So is that typically how you introduce ozone into pain areas? I mean, I know rectal ozone therapy is a big thing in biohacking. So, but that's obviously not for chronic pain. That's for just trying to clear out some toxin or like bad bugs in your lower colon.
Same concept.
Yeah.
Yeah. So rectal, I'm not, that's not part of my toolkit, sure, as they say. Mm-hmm. But I'm sort of a part of that community. So it's the same concept, as you said, the bad bugs, right? So we realized over time, especially as we're looking to alternatives to some in chronic scenarios where we're trying to avoid some of the substances that may cause harm over long term, things like ozone can help correct that again, in equilibrium that exists in these areas if you have a lot of bad bugs, as you said. I mean, I may plagiarize that going forward.
No problem. Okay, so quick rapid fire question. We have a question from Michael Murdoch on the gluten chronic pain connection. Is that something that you see? Is there a chronic pain connection to gluten?
Could you say the question again?
Yeah, it's going to be a short answer. We're just looking, have you seen a gluten chronic pain connection? So gluten, foods containing gluten.
Yeah, so definitely. I mean, gluten in folks who have gluten sensitivity are again going to have that inflammatory cascade as a reaction to introducing gluten into their body. And as we're talking about earlier, the enteric nervous system, meaning the nerves that supply the gut, if they are hypersensitive, are going to sort of cause that wind-up phenomenon where the pain pathways are amplified, and you get that it's sort of an indirect process, but that's how you would establish that connection between gluten sensitivity and amplification of pain. So in our clinic, we often work in conjunction with our clinical nutritionist who sort of works on these things, for example, eliminating gluten or any kinds of other triggers that would cause this cascade to come about.
All right. So we're coming up on time here. Jordan or Avisha, do you have any quick rapid fire questions you want to ask?
One rapid fire question would be, you mentioned the whole icing and cortisone thing. So I know there's been a good amount of debate about the whole concept of rice and whether or not the body's natural inflammation is healthy versus not. My approach to it has often been for chronic stuff, maybe it's really good for lowering the chronic inflammation, but for the acute bit, then as long as it's not extremely inflamed, and if I bang myself and there's a medium amount of inflammation, I try not to ice it. But I'd be curious, just quickly, what's your take on what times the natural inflammation is good versus icing being beneficial?
Okay, so I'm just going to say that back to you. Your question is are you somehow reversing the effects of your body's natural inflammatory response in order by applying ice so as to inhibit recovery of an injured site?
Yes.
Okay. So I would agree with that to a certain degree, and I debate my colleagues on this even now. For me, if you're in my office seeing me, that means the inflammation has gotten out of hand. And in those typically, and in those cases, I do think that ice is very beneficial. Again, Avisha, the joints, particularly the musculoskeletal system, the circulation is very poor. That's how we were engineered. When your knee swells up, it is trying to repair that area. But a lot of times it's not going to be in a reasonable amount of time where it can sort of heal on its own. And so that's why I do think the benefits of ice in terms of reducing the pain and loss of function associated with an injury outweighs the deleterious effects of inhibition of inflammation.
So as long as I don't care at all about pain, then it's better to not ice. That's my takeaway here.
Yeah, I guess. But then that would sort of defeat the purpose of this conversation, which is caring about chronic pain.
Well, no, I care about chronic pain. It's just the acute stuff. As long as I know it's going to go away, I can handle it.
Yeah,
yes, I suppose in the acute setting, you could sort of wait it out. But I think in a chronic setting, it definitely makes sense. So yeah, I think you could argue either way. My goal is to sort of get things under control so we can move on. And so I usually find ice to be very beneficial.
Great. That's awesome. And it's super accessible. And I'm sure there's a bunch of people who just wait and deal with their chronic pain because they can't afford all the treatments that are required. Like an MRI is super expensive. You got to jump through all these hoops in order to get it covered. So yeah, that's a little tough, right?
Yeah. And a lot of times, like, you want to figure out how bad the injury is, right? So if you ice it for 3 days and it's not getting better, you may have a much bigger problem on your hands, right? So rather than sort of waiting around and possibly causing a permanent injury, I think it's best to jump on it with conservative management, i.e. rice therapy and, immobilization and so forth, to really see what the nature of the problem is. You can get a lot of clues just from doing those things.
All right, cool. All right, we're going to move on to the final trivia question, and we're going to pose it to you. I know you're a very well-informed, well-read man, so we're going to ask you what your thoughts are. What percentage of released prisoners in the U.S. returns to prison after committing another crime? This is also known as the recidivism rate. And we have four choices: A, 40%, B, 26%, C, 60%, or D, 76.6%.
Why is the last one a decimal? Is that like meant to be a trick? Everyone's going to go for the decimal?
It's all super tricky. It's meant to just trip you up.
So they're actually reincarcerated after being released?
That's right. What percentage of American prisoners are released and then commit another crime and get re-imprisoned?
I'm going to go with 40%.
All right. So I'm going to read the answer here. We actually are going to accept two answers. Most Nordic prisons are incomprehensibly luxurious by American standards. So we are taking this from the article where it compares Nordic prisons to US prisons. So most Nordic prisons are incomprehensibly luxurious, more akin to a decently appointed hotel with all manner of education, worker training, and entertainment facilities, rather than the Stalinist concrete cage of the typical American prison. So rather than being brutally vindictive with their punishment, the main point is rehabilitation, trying the utmost to make sure the convicts are not turned into hardened criminals. Sure enough, the rate of released Nordic prisoners arrested for another crime within 2 years of 2005 ranged from 20% in Norway to 43% in Sweden, and that compares to 60% of American parolees over the same period. So over 2 years, 60% of American parolees end up back in prison. And over 5 years, that rate goes up to 76.6%. So in other words, in terms of controlling crime, America's gigantic mass incarceration complex, stuffed full of people serving decades-long sentences, is completely pointless because 3/4 of them end up going back. So I take the position that incarceration punishment is a failed social experiment. But so, Jordan, on a brighter note, I'm sure we have a winner.
Yes.
Could you tell us who the winner is?
It is Christina Costello.
All right, Christina, congratulations. You win a copy of Ben Greenfield's Boundless book, as well as a free consultation with Dr. Palvia. All right. So, Avisha, help us close this one out.
All righty. Well, thank you, Dr. Palvia. We've all learned a good amount about chronic pain in this time. I still, at some point, am going to have to corner you and talk a little bit more about my own particular issues, but figure that's a little bit more particular than with the general population. So I think we've all learned a lot about how to approach thinking about chronic pain, and even some of the great new approaches that might be able to kick it for once and for all. So thank you for taking your time to come and share your information with us. And we look forward to hopefully having you on again at some point in the future.
Yes.
Thank you so much for having me. I really had fun.
Thank you. Thank you, Dr. Palvia. And thank you, Jordan. Thank you, Avisha, for this wonderful show. Thank you all for joining us tonight. Please do check out our website, biohackthe.world, for all the latest news and updates, and watch some of our videos on Biohacker TV, where we have a complete a curated video library of biohacking videos. There's also info on our next event, which will be on 6/18, Thursday, with Dr. Carrie Gelb. It's all about ocular health. And we also have a special screening of his film. It's called Open Your Eyes. And you're going to be blown away about the fact that we can actually detect over 300 metabolic conditions in the eye before most other traditional means. So you're not going to want to miss that. That's Thursday, June 18th. And if this episode spoke to you, please do share it with a friend or two and leave a positive review. And please do remember to connect with us on social media. And until next time, please take care of yourself, stay hungry, stay safe, and good night.